Anatomy students, and welcome to the part 2 lecture recording of chapter 13 on blood vessels and circulations. We're on veins. After this, you guys will have a lecture exam on Wednesday, April 13th, and look for a study guide posted. But veins, so we talked through arteries, and veins will return blood to the heart. In systemic circulation, they will always carry deoxygenated blood, but in pulmonary circulation, the blood returning to the heart in your pulmonary veins is oxygenated because it's coming right from the lungs. Here are some major veins draining blood into the right atrium. Your superior vena cava returns blood from the head, neck, thorax, and right upper limbs. And the inferior vena cava returns all the blood from your abdomen, pelvis, and lower limbs. And both the superior and inferior vena cava will empty into the right atrium of the heart. So here are the major veins of the body. The nice thing is a lot of the nomenclature of the major veins is similar to the major arteries because they run parallel with each other, and we'll go through some of that. So for example, your external and internal jugular vein externally drains the blood from the head and neck, and internal jugular vein drains the blood from the brain, face, and neck. And they both empty into your subclavian veins. The subclavian veins will form brachiocephalic veins, and brachiocephalic veins join to form the superior vena cava. This is a little bit how that branching works. So here is the superior vena cava and how it splits into a right and a left brachiocephalic vein. And then they just give you the right option here, but they show you how the right brachiocephalic vein branches into your subclavian vein, which goes on to drain blood from your right upper limb. And then the internal jugular vein goes up internally to the brain, and the external jugular vein stays on the surface of the skull. Veins of the upper limbs, then, we have the brachial veins empty into the axillary vein in the armpit. Cephalic veins empty in the axillary vein and basilic vein, and then the median cubital veins connect to the cephalic vein. These are near the elbow, and the median cubital vein is normally the one for venipuncture if you get a blood sample taken. So here are veins of the upper limb, kind of similar but not exact to the artery nomenclature, but the subclavian vein changes names into axillary vein, into brachial vein, and then into the median cubital vein. And you see some branches here, the cephalic vein and basilic vein, and all are draining blood from the arm back into the heart. Then veins of the thorax, your right and left brachiocephalic veins drain blood from the thorax or the rib cage region into your superior vena cava. The azygous veins drain blood from the thorax directly into your superior vena cava, and the internal thoracic veins will empty into your brachiocephalic veins. You have posterior intercostal veins between ribs from the that'll drain blood from the posterior thoracic wall, which will empty their blood into your azygous vein on the right side, and the hemiazygous vein receives that blood from the azygous vein of the left side. So here's a little bit of how blood is drained from the thorax. You see your accessory hemiazygous, azygous vein, posterior intercostal veins that'll go between the ribs, all are draining into either the brachiocephalic or the superior vena cava to drain all the blood back into the heart from the thoracic cage. And then veins of your abdomen and pelvis. So we have your inferior vena cava kind of following parallel with your descending aorta down the abdomen. But eventually the inferior vena cava splits into the common iliac veins, which again will split into external and internal iliac veins. And again, that nomenclature follows how the descending aorta splits as well. So your external iliac vein will drain blood from the lower limbs, emptying into that common iliac vein, and the internal iliac vein drains blood from the pelvic region, reproductive organs, bladder, emptying also into that common iliac vein. The renal vein, you see that renal word, that means kidney. So your renal veins drain blood from your kidneys. And again, this is kind of a nice way to look at the major veins of the abdomen and pelvis and what they drain blood from. And again, instead of just seeing a bunch of red and blue lines in the body, Sometimes it's nice to actually see it laid out like this. So the inferior vena cava, and you'll always notice the direction of blood is now going up back to the heart, to the right atrium. So you'll see your right internal and external iliac vein draining into your right common iliac vein, which will join to form the inferior vena cava. You have lumbar veins, gonadal veins to the ovaries and testes, renal veins to the kidneys, and then suprarenal veins to the adrenal glands, which lie on top of the kidneys. The hepatic portal system is a specialized portal system of venous drainage that has to do with the liver. So your liver is a major processing center for all the substances absorbed by the intestinal tract. So what happens after you eat a meal, all the nutrients that get absorbed into the bloodstream from your intestines get taken to the liver for processing. And this kind of vascular system of bringing blood to the liver for processing is called the hepatic portal system. It begins with capillaries in the viscera or the organs, and ends with capillaries in the liver. And it uses the splenic vein and the superior mesenteric vein. So here we have veins of the hepatic portal system, and these veins are taking blood, inferior, superior mesenteric vein, from the digestive tract and taking it through the hepatic portal vein into the liver, where all those nutrients from the substances you eat will be processed, kind of cleared out and used for different things that your body needs. So this hepatic portal system is kind of a specialized type of venous drainage that's draining blood full of nutrients from your digestive tract, taking it to the liver for processing. Then in the lower limbs, we have femoral veins, which will drain blood from the thigh and empty into your external iliac vein. You have a great saphenous vein, which runs the entire length of the leg, draining from the foot. And then popliteal veins will drain blood from the knee and empty into the femoral vein. And this is just a look at veins of the lower limb. We see our femoral vein, the great saphenous vein, popliteal veins, all draining blood from the lower limb. And a lot of these veins will have those valves in it that we talked about to help with venous return back up to the heart as blood is flowing against gravity. So blood pressure now, we talked about arteries, veins, and now we talk about blood pressure. This is the pressure or the measure of the force that the blood exerts against blood pressure walls. And systolic pressure is always when the heart contracts, and the diastolic pressure is always when the heart relaxes. And we put those two numbers as a fraction with systolic on the top, diastolic on the bottom, and your average blood pressure is 120/80. Anything over that can be a little tricky or cause problems. Many of you probably know how to take blood pressure already because you're EMTs or have taken those courses. But in order to measure blood pressure, we put a cuff around the brachial artery, and then we inflate it to shut off blood flow through the artery. And once we've completely shut off or closed off the brachial artery, we slowly reopen. So here we have kind of the first step where it says the artery is completely blocked. There's no sound because there's no blood flowing back through that artery yet. Then we slowly release pressure from the cuff, and the first sound that we hear, the first kind of squirt of blood that starts to go back through that artery is known as the systolic pressure, at which the first sound is heard. And then you'll hear these sounds, they're called the sounds of Korsakoff. You're hearing blood spurting through that brachial artery as pressure is being released from the cuff. And when the sound appears, the number at which the sound appears is called the diastolic pressure. And that, again, normal blood pressure is 120/80. The pulse pressure is the difference between your systolic and diastolic pressures. So really simply put, if you have a blood pressure 120/80, you just subtract the two and your pulse pressure is 40 millimeters of mercury. And the pulse pressure points can be felt near large arteries throughout the body. And this is just a visual representation of where these pulse pressure points can be found. And you know many of these already: the radial artery in the wrist, the femoral artery, brachial, axillary, facial, common carotid, superficial temporal. You can feel your pulse near your temples. You can feel your pulse behind your knees or around the ankle region and posterior tibial region. Then capillary exchange. This describes the exchange across capillaries walls of nutrients, gases, other ions, and this is due to diffusion. Blood pressure, capillary permeability, and osmosis will all play a role in the movement of fluids across capillary walls. The net movement of fluid from blood into tissues, that just means that the net movement of fluid will always go from blood into the surrounding tissues, and fluid gained in tissues is then removed by your lymphatic system. So here we have the capillary exchange at the arterial end of a capillary. The movement of fluid out of the capillary due to blood pressure is greater than the movement of fluid into the capillary due to osmosis. At the venous end of the capillary, the movement of fluid into the capillary the movement of fluid into the capillary due to osmosis will be greater than the movement of the fluid out of the capillary due to blood pressure. And approximately 9/10 of the volume will return back into the capillary. But just this shows how difference of pressures and osmosis and diffusion will play a role in how fluids move out of your capillaries and then back into the capillaries. Local control of blood flow is achieved by relaxation and contraction of sphincters called precapillary sphincters that will control blood flow into these capillaries, and the sphincters will relax to increase blood flow through the capillaries. Precapillary sphincters are controlled by metabolic needs of the tissues, and concentration of nutrients also control the blood flow. And blood flow will increase when the oxygen levels decrease. So here's just a look at these precapillary sphincters. It will relax to encourage and dilate so that blood can flow through into the capillaries, or the smooth muscle of the precapillary sphincter will contract to decrease or stop blood flow into that capillary bed. Nervous control of blood flow, we have a vasomotor center in the brain, part of the sympathetic division, which controls blood vessel diameter. Vasomotor tone is the state of always partial constriction of your blood vessels, and an increase will cause the blood vessels to constrict and blood pressure to go up. Hormonal control of blood flow, the sympathetic division also regulates hormonal control of blood through the release of hormones like epinephrine and norepinephrine from the adrenal medulla of the adrenal gland. And in most of your blood vessels, these hormones, epinephrine, norepinephrine, causes constriction, which reduces blood flow. But in some tissues like skeletal muscle, cardiac muscle, these hormones actually cause your blood vessels to dilate, increasing blood flow. And epinephrine and norepinephrine, those are your adrenaline hormones. So they're getting your body ready for activity. So they will increase blood flow to your skeletal muscle, to the heart, to get your body ready for activity. So here's nervous regulation of blood vessels through sympathetic nerve fibers, either increase or decrease in the diameter of those blood vessels to control blood flow. Mean arterial pressure, so an adequate blood pressure is required at all times to maintain blood flow through the blood vessels of the body, and that's good. We want blood flow going to the tissues that need it. Several regulatory mechanisms ensure that blood pressure remains adequate for this task. And mean arterial pressure is a calculated value that reflects an average arterial pressure in various vessels of the body. And this mean arterial pressure is equal to your cardiac output times peripheral resistance. Remember that cardiac output, and it's okay if you don't remember, it's equal to your heart rate times the stroke volume, the amount of blood ejected from the ventricles. And peripheral resistance is the resistance to blood flow in all the blood vessels. And if we multiply those two together, we get the mean arterial pressure. This will change in response to changes in heart rate, stroke volume, or peripheral resistance. And it even changes over our lifetime. So at birth, the mean arterial pressure is about 70 millimeters of mercury. And it's maintained at about 95 millimeters of mercury from adolescence to middle age, but it could reach up to 110 millimeters of mercury in a healthy older person. Baroreceptor reflexes, these will activate responses to blood pressure in a normal range. They respond to a stretch in arteries due to an increased pressure, and they're located in the carotid sinuses and the aortic arch. The change in peripheral resistance, heart rate, stroke volume, these will all change in response to blood pressure. So here's just the baroreceptor reflex mechanisms. These baroreceptors are found in your arteries, the aortic arch, the carotid sinus, to kind of keep their eye on blood pressure, and then to sense that blood pressure changes, and then to make a change, either to decrease or increase heart rate and stroke volume according to those blood pressure changes. Here's the baroreceptor effects on blood pressure, whether you have blood pressure increasing or decreasing, and how those baroreceptors in the control center will detect an increase or decrease in blood pressure. And then they'll have an appropriate response, either tell the heart rate and stroke volume to decrease, blood vessels to dilate, to bring blood pressure back down, or increase heart rate and stroke volume, and increasing constriction of blood vessels to increase blood pressure again. The chemoreceptor reflex, chemoreceptors are sensitive to changes in chemicals like blood oxygen, carbon dioxide, and pH. These chemoreceptors are located in carotid bodies and aortic bodies, which lie near your carotid sinus and the aortic arch, much in the same location where your baroreceptors were located. They send an action potential along a sensory nerve to the medulla oblongata, where there's an appropriate response then to any kind of mischange or misalignment of blood oxygen levels, carbon dioxide levels, or pH levels. The adrenal medullary mechanism is when we have stimuli increasing sympathetic stimulation to the adrenal medulla. The adrenal medulla then secretes our adrenaline hormones, epinephrine and norepinephrine, which will increase heart rate and stroke volume and vasoconstriction, except for it will vasodilate the blood vessels going to your skeletal and cardiac muscle. So this is control using the adrenal medullary mechanism, using the hormones epinephrine and norepinephrine to stimulate a sympathetic nervous system response, getting your body ready for activity. So you're secreting these hormones for that. The Renin-Angiotensin-Aldosterone system or mechanism is a really interesting system that our kidneys use to counteract any sudden decrease in blood pressure or blood volume. So a reduction in blood flow will cause your kidneys to release a hormone called renin. Renin acts on angiotensinogen to produce angiotensin-1, which then gets converted to angiotensin-2. And the big thing here is that angiotensin-2 causes vasoconstriction of your blood vessels, as well as it acts on the adrenal cortex to release a very important hormone called aldosterone. Aldosterone is important because it tells your kidneys to conserve or retain water and sodium. So it results in less water lost in your urine and trying to maintain blood pressure that was decreasing. So here's a look at the Renin-Angiotensin-Aldosterone mechanism. It's when anytime there might be a decrease in blood pressure or blood flow, the kidneys will secrete renin, which will convert angiotensin-1 to angiotensin-2, and it has kind of a twofold effect. It tells your adrenal cortex to secrete aldosterone, and it also helps with vasoconstriction of your blood vessels. And aldosterone tells the kidneys to retain water, to increase blood pressure and blood volume, and vasoconstriction will directly increase blood pressure as well. ADH, the antidiuretic hormone mechanism. So this is, we talked a little bit about this already because it's used in the angiotensin-aldosterone system, but nerve cells in your hypothalamus will release antidiuretic hormone when concentration of solutes in your plasma increases or blood pressure decreases. And ADH will tell your kidneys to absorb more water. So that means that you'll urinate less frequently because the water is being absorbed back into the kidneys. And this results in a maintenance of blood pressure and blood volume. So that's how antidiuretic hormone works. Released from the posterior pituitary, this is ADH, telling your kidneys to retain more water. Long-term control of blood pressure, then, we have lots of different things that help this. Chemoreceptors help control long-term changes of blood pressure, and you can see that here, blood pH increases or decreases. That pH is a concentration of hydrogen ions, so it will be picked up by these chemoreceptors to try to get blood pressure back to where it should be and blood pH back to where it should be. A little bit of aging in blood vessels, and this is kind of where we end. You should know these for your next exam. Arterial sclerosis makes arteries less elastic, and atherosclerosis is formed from the deposit of materials in artery walls like plaque. And different factors that can lead to atherosclerosis are lack of exercise, smoking, obesity, diet high in cholesterol, trans fats, and some genetics. And this is a look at an atherosclerotic plaque that's building up due to one of those factors that was just listed. And it can get scary because this plaque can eventually lead to a blockage or just less blood flow through the blood vessel, which means that wherever that blood is going to, less of it is getting there, and that can lead to problems as well. So thanks for listening to this part 2. You guys have a test on Wednesday. Take a look at the study tips, and we will see you on Wednesday for your exam. Take care, everybody.